Right, this is now the exciting time for us. This is the part that we look forward to. Last year, we started a competition and we asked emerging researchers on our continent to apply for funding to travel to our meeting and to present their work that they're doing. We got some funding from Boston Medical Center, I think, Boston University or Boston Medical Center, and we were very pleased to be able to offer that. And it was a wonderful showcase of the brilliant young people that are coming up on our continent. And so we're very excited to repeat that this year. And there were some challenges last year regarding travel, visas to South Africa. So we had some learnings, and so this year we did things a little bit earlier. So thank you very much to Senite and Ste and other colleagues who helped us to do these things earlier. And I was very excited that we received, I think, 16 applicants. We asked people to do a short video recording of their presentations of our PowerPoint slides, and we had judges that looked at them and viewed them, and we selected the top 10. We then tried to arrange visas and travel quickly earlier this year. And so it's great that we have 8 out of the 10 people that are to present, which is better than last year. The first lady is Rosine Baseke, and Senite and I were having a conversation because I said she's Kenyan. You know, Kenyans can just rock up to our borders now if they're coming here to stay for a few days. And just realized actually she's not Kenyan. She's actually from the Democratic Republic of Congo. She just happens to work in Kenya, in Nairobi. So I think we'll have to look at those challenges again and do a little bit better next year to make sure that people apply in time. She says that she wasn't able to get the right documents to apply for her travels in time because she needed stuff from her employers as well to get all the documentations correctly. So the first presenter is Dr. Favina. If you can come up, please, sir. The bios are from page 9. Alain Favina is a psychiatrist. He works in Uganda, but he is from Burundi. And he'll be talking to us about stigma in Uganda. So we're looking forward to that. 10 minutes presentations, and then 5 minutes time for Q&A, please. Thank you very much. Welcome.
Good afternoon, everyone. And thank you very much for the nice introduction. And also thank you very much for people who have been coming here in front to present to us nice things. And I hope I will also present nice things. So I'm going to talk about caregivers, okay? And I'm going also to talk about stigma. And lastly, I'm going to talk about patients, mainly adherence to treatment and patients' quality of life. I want to start by reminding you something that Dr. Angela said yesterday about the family. She said that the family was part of the journey. And I also think here among us, there are people who have ever been caregiver to someone, or someone in the family has a mental illness, or like we have ever seen someone like a caregiver. So I know we know how hard it is to be a caregiver. So before going far, I want to to give you some kind of picture of how is the health system in Uganda, just to understand the role of caregiver and why it was important to do this study. in southwestern Uganda or in Uganda, we have few institutionalized settings. So the hospital that we have, the referral hospital that we have, they have psychiatric unit where people come and they can be admitted, okay? Then they are admitted with their caregivers, okay? So according to a study conducted in 2021 by Kwobah, they found that the duration, the length of stay is just about 6 days. So you can understand, after 6 days of being inpatient, people go home. With who? With their families, who become their caregivers. So caregivers, in short, they are part of the health system. They help us to help patients in day-to-day needs to the patient, but also to provide assistance for people who have poor functionalities, but also to even escort patient for review. So they are really important. So let me then talk about stigma. Stigma is widespread. We know stigma, mental health stigma is widespread, and people having mental illness are stigmatized. However, they are not the only ones stigmatized. Even people associated to them, parents, children, siblings, cousins, friends, they can be stigmatized because of being affiliated to them, and that is the affiliate stigma. And these people, these caregivers, these family members who are taking care of them, once they are stigmatized, they can be in good position to provide care to the patients that they are supposed to give care. So we then conducted this study to find out what is the prevalence of affiliate stigma, okay, in southwestern Uganda among caregivers of patients living with mental illness in southwestern Uganda, but also what are the associated factors. Okay, that was our second objective. But we wanted also to go beyond only the scope of being a caregiver and try to find out, is there any relationship between being having affiliate stigma and adherence to treatment among patients. And also the last objective was about, is there any relationship between affiliate stigma and quality of life of people living with mental illness? So to answer to those questions, we used these methods. It was a cross-sectional study. We enrolled patients and their caregivers. We did a dyad. So for each caregiver, we were enrolling also the patient. So in total, we enrolled 770 people. And for assessing, we used tools that are validated for all variables that we assessed. And the first one, the ASS, it was affiliate stigma scale, and the other tools were there. We followed all ethical approval and considerations, and analysis was done. Then we got results. So the results was that affiliate stigma is affecting more than half of caregivers of people living with mental illness, and the prevalence was very, very high at 60.97%. And remember, the second objective was about associated factor. We found that one of the associated factor was the number of patients carried by the caregiver. So if a caregiver is taking one or more, is caring for one or more caregivers. Also, we found that the other variable was about being more than one caregiver for one patient. So if in the family people are many caring for one patient, that one was associated to the affiliate stigma. But also having a depression was also another variable that was associated to affiliate stigma. For our third objective, we had to look at the affiliate stigma and its association with the adherence to treatment. And we find that the increase in the affiliate stigma is associated with reduction the adherence to treatment of people living with mental illness. And that was the third objective of this study. For the last one, we found also that affiliate stigma was also associated with quality of life of people living with mental illness. And as conclusion, we find that there is a high prevalence of affiliate stigma among caregivers of people living with mental illness. But also we find that there are some factors that are associated to affiliate stigma, and we found these affiliate stigma is associated with poor adherence, like there is a reduction in adherence to treatment among people living with mental illness, and that was also the case with the quality of life. And we really recommend to all of us as healthcare provider to screen to talk about stigma when we are doing our daily practice, but also to get time to assess about caregivers when they are coming, because as you saw, we assessed about depression, and 25.19% of them were depressed. Okay, so it is also important to assess about that, but also to do some psychoeducation during our session so that we try to reduce this affiliate stigma. For researcher, we need really to do some other research. I found during research that many studies have been conducted, but they are either focusing on patient or on caregiver, but really to find this connection and improve it will help us to improve the quality of life of people living with mental illness. I would like to thank you for listening, and Thank you also, maybe before me, thank you also, AG Mechai, for this opportunity to come here. Also, thank you for, actually, I got a chance to come with my supervisor. I had a supervisor for this project, Dr. Shaba, who is the head of Department of Psychiatry Unit at MAST, Mbarara University. And also, I would like to acknowledge the founding agency that founded this research, the NHR and Royal Society of Tropical Medicine and Hygiene. Thank you very much.
Thank you. Thank you very much, Dr. Favina, and great talk. Do we have time? Well done for finishing on time. Do you have time for questions? Any questions for Dr. Favina? Yeah, you can start here.
Thank you for your presentation, Dr. Favina. I'm just a little curious. What we know, you've told us that the stigma exists. What do you think are some of the factors that influence stigma in Uganda, where you come from? Is it religious? I'm just curious to know. Thank you.
Thank you very much. As you said, there are many factors that influence stigma. And one of them, there is a study which was conducted before. It was conducted in 2019. They found it's about beliefs. They have poor knowledge about the thing. Some of them believe that having a mental illness is because of being bewitched, or there is your family did something bad in your past. So there is some beliefs. As you say, but also in that paper they were citing how people believe also that mental illness is due to poverty. So there is really poor knowledge, but also beliefs that influence the stigma that people living with mental illness are having. Thank you.
Thank you. Any other questions? That side. Is there a mic? Thank you, Stay.
I want to ask something. My mother died of dementia, and then I had no much knowledge about psychiatry. And being the last born, and my mother was then, when she died at 83 years old, I suffered stigma alone because I lived with my mother And you know, with dementia, the way they're aggressive, they can walk out and they don't know how to come back in the house. So like, people thought maybe she did something bad. You try to convince them it's dementia, it's mental health, and it's a disease like any other. She needs love. You don't like to reject her, and anybody can be sick. So when the doctor is talking about the stigma, it's real. The stigma is real. And at times you go to work like you're in your own world. You're supposed to serve patients. You remember what you've left at home. You remember what you're going through in the community. And I think the caregivers most of the time are a forgotten lot. We concentrate a lot with the patient and the outcome of the patient, and many other times we forget about the caregivers. And the caregivers, they are left a forgotten lot. And I think now as people who understand psychiatry, we need to think about the caregiver. I don't know how, but we need to. At times, the caregivers can go to drain together with the patients. Thank you.
Thank you very much. That is really, really helpful. And thank you for sharing your lived experience. Thank you.
Okay, thank you very much, Alain. It's fantastic. And Elaine and I had a brief conversation yesterday as we were walking amongst the vineyards, and he's really keen to do more work and more research. And I think people back in Burundi are going to be proud of you, young man. Thank you very much. Well done. Looking forward to more work from you. Next up is Dr. Abdul Jalloh. He's a young psychiatrist, recently qualified psychiatrist from Sierra Leone. His, I think, his journey epitomizes why we need HMHI, because he wanted to do psychiatry, but he could not specialize or train in Sierra Leone at the time. And so he moved to Kenya and worked and studied in Nairobi. And we met towards the end of that time. He went back to Sierra Leone, and he's been involved and has been in the newspapers and with really upskilling people in Sierra Leone. So we're looking forward to your presentation. He's also done some studying in the UK after that, and I think with Partners in Health, they've really tried to change things for Sierra Leoneans. So looking forward to your talk. You've got 10 minutes, please, my man. Thanks.
Thank you, Prof, for the continued support and mentorship. And thanks AGMHI for this opportunity. And I bring you greetings from the land of diamonds and golds, a land with most beautiful natural beaches and with a lot of opportunities to collaborate and partner. My presentation is a qualitative study that is looking or that looked at community health workers' perception and of depression and of barriers and facilitators in mental health care in Sierra Leone. This is the outline of my presentation. In Sierra Leone, we have suffered a lot of traumatic events, including the Ebola and the 11-year-old civil war mudslide. As a result, there is a huge burden of mental disorders in Sierra Leone. However, there is a 98% treatment cap in terms of mental health care. And this has been attributed to several factors, including lack of resources, attitudinal or cultural beliefs. Community health workers form bulk of the health force that provide health care service to the population, about 1,500 of them. And the government have trained some community workers on mental health care, especially on MHCAP, but this training is inadequate. That has resulted to huge mental health literacy. And this study or community health perception on depression as study has never been conducted in Sierra Leone. So this is the first study so far that will look at their perception and experience in terms of healthcare, of mental health care delivery in Sierra Leone. To help me understand their perception, 3 questions were used to guide me. One is looking at their knowledge, the second one is looking at their perception, and the third one looks at their experience during COVID-19. We employed a qualitative study design, cross-sectional, and we use purposeful sampling and snowballing to recruit a respondent. We also use gatekeepers who advertise the flyers in community health workers' WhatsApp groups. However, these gatekeepers, they didn't have access to the personal information of the community health workers. We use Zoom to collect data remotely in Sierra Leone from Scotland. By then I was in Scotland. And we also use a case vignette that depicts an hypothetical patient with depression and suicidality. And then we develop a semi-structured interview guide, and we use hybrid thematic analysis to analyze the data. For the first question, we use we use a deductive analysis, which, as you can see from the figures, which talks about the first question, and then the other questions, they were analyzed inductively. Result. We had 5 themes and 10 sub-themes. The first theme looked at the community health workers, their knowledge and ability to critically analyze and accurately identify a mental disorder on this patient. And 3 sub-themes emerge. The first theme, about 2/3 of the respondents were able to identify depression. Some says it's stress, and others says it's anxiety. And however, none of them were able to identify suicidality. And also, in terms of the etiological attributions, and none of them were able to identify biological, spiritual, or supernatural causes, but they were able to identify life event. And all the participants agree that professional help is helpful. For the second theme, we look at their experience and their interaction with patient. 2 sub-themes emerge. The The first theme, both they have both positive and negative experiences. And then also, they mentioned that the mental health patient should be treated like any one of us, with empathy, with love and equality. The third theme look at barriers to mental health care. Two themes emerge. One is awareness concerns, and then the other one look at structural barriers. For the awareness concerns, stigma, misconception, religious and traditional beliefs were identified as major impediment to care. And for the second theme, they mentioned that there are insufficient government support to mental health care in Sierra Leone. For the fourth theme, we look at things that will improve mental health care in Sierra Leone. Three sub-themes emerged. The first theme look at increased community sensitization, capacity building, and the establishment and implementation of mental health policies, and the integration of mental health care into other levels of care. Final theme, look at their experiences during COVID-19. And they had mixed experiences also. And they mentioned that the country as a whole was not prepared in terms of mental health care during COVID-19. This study had some limitations. One, it's a cross-sectional study and it cannot be generalized. Two, we use a vignette and interview questions that were not validated within this relevant context. However, I sought permission from the owner of this vignette, Jump, who stays in Australia, and then also the way the data was collected using Zoom. I provided support to the respondent in terms of internet and computers, which somehow biased because it means that those that were not provided with these services did not participate in the study. As a conclusion, community health workers are passionate and willing to provide mental health care in Sierra Leone. However, we need to develop policies. We need to develop and implement policies that will be multi-sectorial, that will help to improve mental health care in Sierra Leone. Also, we need feature landscape research that will look at the fundamental principles underlining the traditional and cultural beliefs in terms of mental health care in Sierra Leone and the status of the way we provide care to the patient. Thank you. These are my references. Thank you.
Any questions? Any questions for Dr. Jalloh? Thank you very much, Dr. Jalloh. If there are no questions, congratulations. Well done. Looking forward to more work from you. Thank you. So the next presenter is a psychiatrist from the west of Kenya, Dr. Edith Kwobah, who I think many of us have know her and worked with her. And so I'm going to ask Lukoye to say a few words, who is, I think, the primary mentor to her. Maybe you can announce what has happened to her and why she could not be with us today. Thank you.
Thank you very much, Bonga. And good afternoon, ladies and gentlemen. Dr. Edith Kwobah started working with me in around the year 2010. So that's about 13 years give or take. She did her her Bachelor of Medicine and Bachelor of Surgery, as well as her M.Med in Psychiatry from the University of Nairobi, and then came to Eldoret to work with me. And subsequently, she earned a PhD at the University of Cape Town under the supervision of myself, Professor Dunstein, and Nastasia Cohen. Edith has done a lot of research, and she was intending to come and showcase some of the work that she has done in Western Kenya, where she has an interest in community mental health as well as public mental health, largely REIT. She has established the only what you might call halfway home within a public general hospital in Western Kenya, the second national referral and teaching hospital in Western Kenya. Unfortunately, she's not able to be with us here. 1 month ago, after having experienced a lot of migraines for most of her adult life, the symptoms worsened, and she went for an evaluation, and they found that she has brain metastasis of cancer. And then, so they found the primary in the lungs, but there were metastases also in the spine and in some of her bones. So a couple of weeks ago, she started radiotherapy, which she completed. And now she has started her chemotherapy, has had her first cycle. I think this is the 5th day after receiving her first cycle of chemotherapy. She sends her regrets. She wishes she was here, but she's dealing with this situation, and we are hoping that she recovers and is able to join us in a future meeting. Thank you very much.
Thank you, Lukoya. Edith has been very brave and spoken up about her illness, and I think it's wonderful that she is seeking support from others, and I think you've said previously that she's quite positive about her illness, and so we wish her well. So I think we are ready now for the first lender. Apologies for that. I think I remember even as I was reviewing, I was one of the judges I was reviewing. I think there was confusion about the lenders as well when we were reviewing your presentation. So I'm glad this is hopefully the correct one now. Thank you so much. Thanks.
Okay, thank you. So I'll just dive into the discussion, and I'm presenting on caregivers' experiences on drought-induced mental health challenges in Kilifi County. And one of the things when I saw this call, I think I was really excited about it because we were doing a lot of work and would sit in our corners and talk about it so passionately. But at like the immediate dissemination, I hadn't thought about it. So when I saw this, I was like, I need to share this out to everyone, and I'm glad I'm doing that today with us. So I wouldn't talk about this because the speakers who were here yesterday, today in the morning, some of them were just the same, and they were talking about, the effects of climate change globally. And one of the things that we were told yesterday, we were told this morning, is about the increases in, the temperatures in the land. And one of the things that I would like to mention about this is the fact that Africa is likely to face some of the immense challenges with regards to climate change, because within the Earth, on the northern hemisphere side, is the direction in which they're likely to be affected by the adverse changes. And 3/4 of Africa falls within that hemisphere. So it means like 32 countries, if not, are likely to experience some of these climatic changes. And Kenya, being the country that I come from and where we did this study, has already faced some of these things. For example, within the northern region and within the coastal line, there have been reports, publications around, drought, around floods, and all other co-occurring events with regards to climate change. So this study, it's a case study of Kilifi County. Kilifi County falls within the coastal line in Kenya, and
it's a county that has several pictures, depending with what you went to do there. So there are people, if I would have pulled one of the pictures, the last one, the one of the sandy beaches, and talk about the first two, they would think probably I'm lying because they've only been to one side of the region. So Kilifi has, it's very distinct in terms of it has its beautiful side. It's a tourist attraction. There are very nice beaches. But at the same time, majority of its population lives within the rural side. And one of the things is, even in terms of the profiling of the county, it has a poverty index of 70%. And 67% of the households are facing food insecurity. And it's still the same county that I'm talking about, drought. And as you can see in the second photo, it has been published by local media a few days ago talking about floods. So when we did this study, we were talking about drought. Now the county is talking about a different story. So in terms of this study, one of the things that we've seen is this county has been exposed to different kinds of drought, starting from hydrological drought where there's no water, to meteorological drought where the land temperatures are so high, to agricultural drought where they plant their harvest and there's nothing actually to get from it because of everything that is happening. And one of the things is there has been a lot of talks around the exposures of, climate change. For example, reduced food, lack of water, lack of sources of income, which results to inequalities and vulnerabilities based on the limited resources that are available. And this has been documented, this has been written in terms of the effects of these exposures on the physical well-being. So in this study, we nested a component of it to understand the mental health outcomes in relation to these exposures. For example, depressive symptoms, anxiety symptoms, and suicidal tendencies. And the reason for this was just to be able to say, as much as it affects the physical well-being, is there an aspect of the mental outcome in relation to those exposures? So that is what our study was about. And our methodology, this was a qualitative study. It was a phenomenological qualitative study, and the essence for that, we really wanted to get the people with the lived experiences, like their narration, to be able to understand, because they're the people who are living in the community. They have a better story to tell. And we conducted 26 in-depth interviews. We did 8 focus group discussions. And this study we did between May and June 2023. As you can see on that photo, it's a colleague of mine together with me and male caregivers during one of the focus group discussions. And in terms of the caregivers, we had male caregivers, we had female caregivers, we had mothers, and in the mothers, we categorized them into 2. We had adolescent mothers, because teenage pregnancy is a concern in that area. And at the same time, we just had mothers who are not adolescents to also understand, for example, their issues. And also we had a group of mothers who had children who had, were also teenage mothers. So that was the distribution in terms of the people who were able to speak to. So there are a couple of things that we were able to pick from this in terms of the different directions that drought could have, could have impacted the mental health outcomes of this individual. And we were able to look at it from different aspects based on their findings or based on their experiences. And one of the things that we were able to pick is they were not able to explain in terms of I was anxious, I was depressed, I had suicidal thoughts, but they had their own, they had their own sort of language that they were able to explain, and from that, during the analysis, we were able to code and, place them in terms of what exactly could this mean. So one of the things, because I'll not go into the whole web, one of the things is, as an effect of drought was environmental degradation. And with environmental degradation, it resulted into food insecurity. We are talking about a region that has experienced 0 to very limited rainfall from the year 2019 through to 2022. And their source of income is agriculture and livestock keeping. So this directly impacts them in terms of what they do. So when there was food insecurity, for some, you'd see in some of the excerpts that I'll present, for some they were able to explain the fact that they do not know where they'll get the next meal to give the family. It's already posing a challenge, like I'm not able to know what I'll do next. I'm not able to put my life together. So they would say the way they would not explain like I was anxious, but they would say I would not concentrate. Maybe I'm walking on the road, someone would say hi, but I wouldn't even realize until they think I've become a snob or something. And something else, even with food insecurity, a lot of domestic violence happened, in the sense that this was a conversation with men, and one of the things they clearly said, this was more like a defense mechanism. When you've worked out the whole day, you've not managed to get anything. In the evening when you come, get a bit violent so that you're not asked why you didn't bring food. And this in turn resulted to, anxiety, because the women do not know, will he come back when he's violent? Will he come back when we have some level of peace? And even just depressive symptoms. And we had one case of a lived experience of a family member from the person who went through that, where they, because of the water scarcity, they lost like 100 herds of cattle. And because the community did not know how to respond to the person, because they felt they were all in the same boat, they were all sailing in the same mud. So they did not know how best to help this person. And one morning they woke up and this person was dangling in a tree, death by suicide, because they could not take it, the fact that they had lost like their source of livelihood. Then there's the absent parenting due to family separation. We're able to see, because they've lost their source of livelihood, they have to look for an alternative means. They had to move to different towns to be able to look for a means of survival. And because of this, there were so many absent parents, children were left in the care of grandparents, children were left in the care of other family members, which in turn led to other issues, for example, teenage pregnancies. And from that, you would see a lot of self-stigma from the parents who left their children behind and ended up into some of these issues. So from the excerpts, I'll not read all of them, but I will pick two. One from a mother in relation to self-stigma around absent parenting, and one from a father in relation to the inability to provide. Or me as an adult, I can manage to go to bed hungry, but it's very difficult to tell my children to go to bed hungry. Trust you me, we go through a lot as fathers. I left and went to work in Mombasa. Mombasa is an adjacent county. We left the children with my mother-in-law. I was later told my daughter, who was in grade 6, was pregnant. I really blamed myself for not being there, and I have so many thoughts. I even quit working and came to stay with them. So these are just a few of the excerpts that we are able to pick in terms of some of these issues that we are talking about. So with that, I would just like to give my conclusion in relation to that. One is that drought seasons are likely to increase in Africa. The one thing we realized at that time, they're experiencing drought, currently they're experiencing floods. So one of the things to think about is, because it's a threat to mental health, and we've seen in terms of the exposures, how are we able to, as a country, be ready for some of these things, for the disaster preparedness. So this calls for a proactive management of some of these drought shocks, and it requires, a multi-sectoral kind of communication, in the sense that we cannot operate in silos as the healthcare practitioners. In the hospital, we have these nice boards showing the number of, mental health cases, mental illnesses have gone high, but we are operating in the sense that we need to understand what are some of these causes. So to be able to understand in a way that we can work together with the other ministries, together with the other departments, to ensure that we are able to cushion these communities. And finally, to engage our communities so that there's ownership of the activities that we do and the sustainability of the activities or the interventions we want to bring. And with that, I want to say thank you and to acknowledge Professor Zul Merali, Professor Lukoya Toli, Amina Abubakar, and Akbar, who are the PIs of the major grant, which is called Uzima. It's a data science project. Dr. Edna Bosire, the county government of Kilifi, all the research assistants who supported us in this, and of course, the participants who took their time to be able to tell us their stories. Thank you so much. Running away.
Well done, Linda.
Thank you.
So we've got time for a few questions. Maybe let me start, and then we can. The first one is just about, I was just wondering if maybe for the larger study, if you've thought about maybe using photo voice as the methodology for looking at like some of the qualitative stuff. Just wondering about whether you've asked people or used that method before.
In this one, even in the larger study, we do not have that component, but it's something that we can think through it. Even
I think
in
it might be powerful to take photos of people, and to for us to kind of have a look and see what it's like, what the lived experiences are like when it comes to climate change, drought, and that kind of thing. But yeah, okay, thanks. Please go ahead.
Thank you so much for your presentation. That was fantastic. I just wanted to comment and say thank you for for having this study that's focusing on drought. I think there are articles out there and there's literature out there that's focused on large events, disastrous events, storms, things like that, and floods, which are incredibly traumatic. But drought is a unique stressor in that it's very long-term and it's very prolonged. And it's not just a one moment in time, it's very spread out. So I very much appreciate that there's gonna be more literature on this. I look forward to seeing the future results of the studies. And just wanna echo, the photo voice would be absolutely fantastic, especially in the context of climate change. It's just a really, really wonderful way to show what families are and individuals are living through. So yeah, thank you.
Thank you.
Thanks. And Dr. Norris, behind you stay. Can you pass her the mic, please? Thanks.
Thank you so much for an excellent talk. I had a question about individuals who suffer mental health disparity and problems. You mentioned the suicide in the family, and you mentioned the pregnant young lady. Are there any support services for both families, actually, or the community? Because it's a community process.
Okay, so within the community, what happens is the link to the nearest public health facility, but there's no picking it directly from the community, but it's rather when somebody self-refers themselves to the healthcare facilities. And the reason for this, we find, for example, within that area, there are 4 sub-county hospitals, and you'd find in a sub-county hospital, there's no psychiatrist, so maybe there's maybe one psychologist, so definitely they're overwhelmed. They might not be able to pick some of these cases. So unless it's on the extreme end of the spectrum, that's when maybe the community thinks to bring them. And in a different study, we were able to see that in that community, the hospital is not the first point of contact, but it's towards the end, when they've tried all other avenues, and the avenues are no longer working, that's when now they find themselves to the hospital.
As a follow-up, we have a similar issue, just as a follow-up, in the States with respect to people losing their farms and the increase in suicide. And it becomes not just 1 or 2 farmers, but it can be a whole nettus of farmers who then feel that there's no hope. So I think this is a very important issue, and particularly because they're also impacted by climate change that you might want to look at as well. But thank you so much.
Thank you.
All right, thank you very much, Linda. Thank you so much. Oh, was there one more? Professor Angie wanted to say one more.
I just wanted to ask,
There's a mic right next to you.
just a quick one. Alcohol, substance use, anywhere in that beautiful network that you wrote, you drew your figure. Was there anything like that?
Yeah, so early this year, we had a very intense ethnographic study within the community, different from this specific project. And one of the things that came out really strongly is the use of substance among the youths in that community. And the one that was most prevalent was cat within that setting. And besides that, there was also the use of bang. So those were some of the common ones. But one of the things, if you were to go there, starting from the highest policy maker to the, anyone within the community, if you ask them what's the main issue with youths here, the first thing they will tell you is the use of substance. So it's a very key thing in that area. And I think just a few weeks, 2 weeks before I came here, there's also a recent study that we're still doing there around substance abuse among the youth.
So I was just wondering why it's not in your beautiful figure.
In this specific metrics.
Yeah.
Yeah, so next time we'll consider that is there.
All right, let's continue. The next young man is a young man from my university. Is unfortunate that he has the same first name as me. So if I get into trouble, then I'll blame Mafuze for whatever misdeeds I've done. Dr. Mafuze was has just completed his term as a chief registrar at University of KwaZulu-Natal. He's a bright young man. I'm sure he's going to go very far. He's got lots of interests, wonderful leadership in the university globally, not just in psychiatry. So we're looking forward to your study and looking forward to hearing from you. Dr. Mafuze, thank you.
Good afternoon. Thank you to, I guess I say Bonga 1 and then I'm Bonga 2. Like there was Linda 1 and Linda 2. So this afternoon I'm just going to share my experience with the research that I'm doing as part of my master's project for my MD degree. So it's titled The Prevalence of Neurocognitive Impairments in Chronic Pain Patients who are attending a tertiary pain clinic in one of the towns in KwaZulu-Natal. So today we spoke a lot about bidirectionality, collaboration. There's also, for my research, a lot of bidirectionality in terms of neurocognitive impairment and chronic pain, which was one of the reasons why I had chosen to do this study. So when we're talking about neurocognitive impairment and chronic pain, there's a lot of common associations in them. And with neurocognitive impairment, we're referring to deficits in things like concentration, language, memory, verbal fluency. I'll later share how we try to measure these. And then when we're looking at chronic pain, worldwide there are various definitions for references to chronic pain. But for the purposes of this study, we're using chronic pain as persistent pain that persists beyond 3 months. So anything less than 3 months is acute pain, which is what you start feeling when you've been sitting here for too long. So looking at neurocognitive impairment and chronic pain, the epidemiological data suggests that worldwide in the general population, there's actually more than 50% of patients who have chronic pain who also have comorbid neurocognitive impairments. These can either be tested or they can be reported by the patients. So what I also realize is that there's inadequate management programs for these patients who suffer both of these. And in South Africa specifically, there is literally no data, or there's a lack of data that looks at this chronic pain and neurocognitive impairments. So when I rotated through the chronic pain clinic during my neuropsychiatry rotation, I had jotted down some of the questions where I was looking at. In South Africa, I see the general population globally, which is mostly data from European countries or from the Americas. So what is the actual prevalence in our setting in this KwaZulu-Natal area in Pietermaritzburg? And when we say neurocognitive impairments or deficits, what domains are being affected? Because neurocognitive impairment is a very broad term. And how does it have any impact on the level of functioning for our patient? Because when you look at your DSM-5, there's a lot of talk about conditions affecting functionality. So now when we're thinking of chronic pain, what levels of functionality can it affect? Or is it the neurocognitive impairments themselves that can cause a drop in functioning? And then also just come up with some risk factors that I think could be contributory. So the study design is that of a quantitative, observational, and descriptive study. So it's done in a tertiary hospital called Gray's Hospital, which really sits in the Midlands of KwaZulu-Natal. It serves a variety of a catchment area. There's urban, semi-urban, and also informal settlements. So the pain clinic that we worked in, it runs on Fridays and also runs on Wednesdays. So this pain clinic is ran mostly by an anesthetist and also psychiatry. So trying to figure out this collaborative efforts in managing some of the comorbidities that our patients do face. So an adequate sample size for my study based on other researches that have been done was deemed to be 121 participants. And then with the inclusion and exclusion criteria, for inclusion criteria, I included participants who were aged between 18 and 65, and then they had to be English speaking. understanding and writing for them to be part of the study, because some of the measurement tools that we use in our setting are only validated for English. And then, yeah, with other inclusion criteria. But most precisely for exclusion would be the extremities of age. So if you're less than 18 or you're more than 65, you're excluded. Or if you had a primary organic brain problem, such as things like neurosyphilis, could be epilepsy, maybe a traumatic brain injury. So we did exclude you from the study. Or if on the day that I was doing the data collection, there was some psychological or physical distress that could not make you participate in the study, then those people were also excluded. So my measurement tools, I had a clinical data information set that records the social-demographic profile of the patient, past medical history, medications that the patient is taking, the types of pain syndromes that they have, which ranged from post-operative pain yeah, majority of my patients, I think, had mostly post-operative pain. Others were joint pain, and then fibromyalgia. There were various different syndromes of pain. And then in terms of level of functioning, I also had the PSMS, which is the Physical Self-Maintenance Rating Scale, which looks at functionality, or the ADLs. So looking at things like grooming, kitchen, financial management, knowing how to get to the hospital, taking your medication, so various types of things. And then to collect my data, I was using RedCap, both on mobile and also on my laptop. And then the data was extrapolated or exported into Stata. So I must say that with my MEd, I'm currently at my manuscript stage, so still emerging with a lot of results. But for now, from the 121 patients that eventually were part of my sample, we see that actually there were more females than males. So females, there were 66 participants, and males about 55, which is almost equal-ish. And then what I noticed, though, was that if we're looking at the male side with the 55, with the two different tools that I used to measure the cognitive impairment, so I differentiated them specifically like that with MMSE, which is your mini mental state examination. 25 out of the 55 males actually failed the score. So when I say you have a failed score, or when you are diagnosed with a possible neurocognitive impairment, for the MMSE, if you scored a score less than 24, then you are deemed to have a neurocognitive impairment. And then with the MOCA, if you score a score less than 26 out of 30, it's deemed also a neurocognitive impairment, or possibility of neurocognitive impairment. And aligning with most of the research data, that the MOCA is actually more sensitive than the mini mental state examination in detecting neurocognitive impairment. So overall, out of the 121 participants, 66 of them have neurocognitive impairment by MMSE, and then 89 out of the 121 had by MOCA. It's important to note that for this, there was at times where someone may have impairments with the MOCA, so having a score less than 26, but have a normal mini mental examination. So even again here, it's still showing that the MOCA was able to pick up more than the mini mental state examination. So then I just had to try compare the different scores between the two. So when we're looking at the MOCA, if you check on that first bar graph, like out of 5 for executive and visual spatial testing, with the participants, they averaged 3.1 out of 5. Language, they were averaging around 5.9 out of 8 points. Attention, 4.8 out of 6. Orientation wasn't really affected in both tests for the patients that were coming in. So like 5.9 out of 6, whereas on the other one, orientation was like 9.4 out of 10. So what I realized though is that with all of them, all the cognitive domains were affected in some way or the other. And then I think with my study, the limitation is that obviously this was cross-sectional study, and then with the population size, looking in one unit or one hospital at the pain clinic, it's too much of a small number, and there's a lot of biasness in that. And also the tools that are used do not consider like the individual factors for the level of functioning, because you may interpret for some patients that with the chronic pain, they may have maybe a spinal problem that they're on a wheelchair, but they scored like 100% for their MOCA, 100% for their MMSE, but their level of functioning can still be affected in one way or the other. And then obviously language, very difficult to generalize the data because KwaZulu-Natal predominantly an African group that is there, with Zulu being our main home language. So I really had to get people who knew English to participate in the study. And then obviously my study did not look at some of the factors that we know can contribute to neurocognitive impairments. And also with the bidirectionality, it can be very difficult to completely say that, no, this neurocognitive impairment is directly from the chronic pain, or the neurocognitive impairment is from a secondary problem, could be like a mental illness that the person could be having. And it's actually quite a complex thing. So I didn't look at association as yet. So I think throughout in general, overall, the findings are in keeping with the prevalence in the general population, as I introduced, that more than 50%. And I think for this study, we had a finding of about 55% of the patients who are attending in the clinic who did have neurocognitive impairments. And obviously, all of the cognitive domains are affected, and the level of functioning was actually varying between the individuals. So it's difficult to associate the level of functioning with the neurocognitive impairment. And then there are also other clinical and biological factors which have an impact on the development of neurocognitive impairments. So in conclusion, chronic pain and cognitive impairments are interconnected and can have a profound impact on the individual's life. And I believe that we still need more research to better understand the underlying mechanisms and to develop effective interventions. And by addressing the cognitive impairments in chronic pain, healthcare professionals can improve the quality of life of our patients. And I think what I learned mostly from this, working in the pain clinic, I got to meet the likes of Michelle Baker and Alison Bentley, who are from the pain, who from the Sleep Society, but also involved in pain, and me from psychiatry, being involved in pain, and knowing that sleep can affect chronic pain, can affect mental illness. So there were a lot of factors that were involved. But I think most importantly is that we can identify that chronic pain can lead to neurocognitive impairments. So we need to invest in cognitive interventions, such as cognitive training and mindfulness techniques, which may alleviate the cognitive impairments and improve overall functioning. Thank you.
Thank you very much, Dr. Mafuze. Any questions?
Thank you so much, Doctor. I'm Neze Swatete. My question is around language. I didn't quite understand what you were saying about language. Can you just explain that to me? Us to again, please.
Okay, English is not my home language. I'm joking. So the reason, so what I was saying is that for me, part of the inclusion criteria was that my participants had to at least read or know how to read or write English, because the studies tools, the MMSE and the MOCA, is in English. So we don't have any validated tools that can be translated into another language and be offered to the patients. But the advantage is, I think here in the Western Cape, they have the MOCA in isiXhosa, but in KZN, we only just have the English versions. So it's not reliable for me to offer a cognitive test in an interpreted or translated version. I think we need validated, reliable translated versions to give to the patients.
That is correct, but we don't have a lot of time, unfortunately, to keep going back. But he's absolutely correct. We do need properly done, validated scales to measure these things. Yeah.
Thank you. So now I just had a quick observation. You've done, the presentation is very good, but my eyes focus on the numbers, and I'm hoping you've done some statistical analysis so as to arrive at a conclusion that those differences are actually significant. Otherwise, maybe they're just visual differences and not statistical.
Yeah, no, definitely. I think, like I was saying in the introduction, that there is evidence, but there's very limited data that helps to assist with this. So one of the references that I had used was assuming that in the general population there's a 20% prevalence rate. So then looking at our population and size in KwaZulu-Natal region, with the assistance of my statistician, we're able to arrive that this 121, as low as it may be, or as it may look, it had at least included a significant 95% confidence interval for us to be able to at least make an assumption. But then obviously we do need bigger numbers or bigger studies for that. Yeah.
I think he was talking about the results. So have you taken the results to the statistician, and has he done some analysis to show
yes,
that?
Yeah, so it's some of the results have been done. Like I said, I'm in the manuscript phase of the study, so it's not yet complete. Yeah.
Yeah. So, but it will be definitely done by the sets. Yeah, it will be definitely. Okay, so thank you so much, Dr. Mafuze. Unfortunately, we don't have a lot more time. Yeah, you can continue having conversations. Apologies for cutting people short, but you can continue having conversations after this. And there's a book, a wonderful book by No Violet from Harare, I think she was originally from Zimbabwe, who wrote that we need new names, more names. So the next speaker is also Linda. we really, parents of Kenyans and South Africans really need new names. So Linda Kawiri Micheni is from Nairobi, from Kenya. And she is just finishing her master's in clinical psychology, and she'll be talking to us about climate change. Looking forward to it.
Thank you. Good afternoon, everyone. Good afternoon.
Good afternoon.
It's a pleasure to be part of this conference. And as you can see, it's climate change. But let me start with two health factors. Rising temperatures are associated with increased aggression and violence, resulting to high rise of psychotic cases in community, and access to green spaces and nature has positive impact of mental well-being. My name is Linda Kawira Micheni. So Linda means in Swahili protector, and Kawira means in Meru dialect a hard worker. So yes, Linda Kawira is a protective and hardworking lady. How does climate change affect mental health? And in this presentation, I'm going to share with you a profound impact of climate change on mental well-being among the vulnerable communities in Kenya, highlight challenges and mental health implications and psychological tools. So we're going to dive, we won't look much. I've written a lot, so you will see I won't be reading, but I'll just share quick notes on my presentations. Trying to understand the climate change in Kenya, Lately, there have been high rise on climate change in temperature relations, reactive rainfalls, drought, and increased frequency on extreme weather events. And it is hereby that we're going to see the mental health challenges that communities which are vulnerable in Kenya face some challenges. Like, let's start with the vulnerable communities, which was my target group. And in this case, when I shared populations that are in rural areas, and in these cases, rural areas, I mainly wanted to have that thought of the pastoralist communities, coastal communities. The Linda was saying about Kilifi, which is a coastal community. Indigenous communities who are deeply connected with ecosystem, the marginalized groups like the ethnic and religious minorities, refugees, internally displaced persons. We also have urban slum dwellers. It also affects women, children, and those reliant on agriculture and natural resources. Mental health impact of climate change. What are the psychological consequences of extreme weather events caused by climate change? From anxiety and depression to stress and trauma, individuals are grappling with emotional challenges resulting to mental health impacts like eco, anxiety, and climate grief, trauma and natural disaster, climate migration and forced displacements. We also have health risk and anxiety, environmental conflicts and stress, impacts on children's mental health in education, health, and family stability. Eco-anxiety and climate grief are emerging psychological phenomena tied to climate concerns, which result to emotional distress, experience like anxiety, fear of displacement, loss and grief, helplessness and hopelessness, depression, conflict and tension, eco-anxiety, the persistent worry about environmental threats, resilient fatigue on communities that are repeatedly facing climate-related disasters, health concerns like malaria, cholera, and concern for the future generation. So my topic, I'm so interested with water scarcity. Why water? Water is a center of focus in climate change, and it's both primary drive to climate change and in human beings. It is crucial in both physical and mental health for organ function, temperature and mood regulation, stress reduction, and quality sleep among others. So water scarcity results from uneven distribution, prolonged inadequate rainfall, competition for water resources amid population growth, and heightened agricultural demands, often affecting rural water access and inadequate infrastructures. There are limited case studies and data findings published in relation with climate change and mental health. And I'm looking forward to be a primary researcher in this field in parts of climate change, water scarcity, and mental health in Kenya, with more concentration on community-centered approach. In this case, urban center, Nairobi, the capital city, and our northern part where we experience a lot of heat waves, that's in Turkana. So my title, I wish it to be Integrating Water Resilience for Mental Health. In this presentation, I presented a case study done by APRIC, which is, it's based in Nairobi. It has made a lot of research, and actually being in clinical, most of our data we share with APRIC. So we might not find them in our clinical settings or community-based, but we do share information. They in collaboration with facilities that are under the government and county levels. So in this case, they did with informal settlement, which is Kibra, our slum, our biggest slum actually. And they were doing in relation with flooding, which is a recurring situation in Kibra because of poor infrastructures. And in relation with flooding equals mental distress and anxiety. Are any effective coping strategies for individuals dealing with climate change? Yes, there are. Effective coping strategies for individuals dealing with climate change include promoting mental health awareness and education, providing psychological support and counseling services, building resilience through social networks and activities like tree planting, engaging with kitchen garden projects in our neighborhood, investing in climate resilient infrastructure, conducting disaster preparedness drills, promoting water conservation and renewable energy adaptation. In Kenya, government initiatives like afforestation and reforestation offering free tree seedlings in every county to contribute to these efforts. And this week on Monday, we had on 13th November, we had a public holiday just to plant trees. It's almost. Yes, try. That's why I had notes, because I had a lot to share. Let's go deep to policymakers. Policymakers play crucial in addressing mental health concerns related with climate change. So in this case, since there are so limited informations, I'm going to share recommendation roles, which include creating comprehensive mental health action plan for climate change, outlining strategies for awareness raising, allocating resources and building capacity to address mental health impacts. They should establish community-based mental health support to enhance access to care and integrate mental health into climate adaptation plans for vulnerable assessments, identify at-risk population, and incorporate mental health support measures for creating awareness campaigns. I won't go much about climate change and mental health equity, but well, I can just say that we need to have more food security interventions, legal and policy frameworks, participation and representation of all stakeholders to increase the availability and accessibility to mental health services in communities, and establish climate-focused support groups, since we are social beings. And as I conclude, The implications of climate change on mental health in Kenya is significant and relatedly to other countries and demands attention and action. So let's work together for sustainability and mental resilient future. Thank you so much.
Thank you. Thank you very much, Linda. Any comments or questions for Linda? If not, thank you very much. Have a wonderful. Thank you so much for finishing that. Okay, so the next presentation is from Dr. Moses Muwanguzi. Where is Moses? Ah, there you are. He's from Barara University in Uganda, and he's a psychiatry registrar and early career mental health researcher, and he's already published a number of publications, so we're looking forward to your talk. Thank you very much.
Thank you so much. Good evening to you.
Afternoon.
That gentleman looks like me, right? Yeah. So okay, thank you. So I'm going to talk about adverse child experience, and I think we've had this since yesterday, right? We've heard about childhood trauma, childhood maltreatment, how climate change contributes and environmental stressors contribute to childhood trauma, and also the impacts on mental health. So I'm passionate about childhood trauma and adverse child experiences. So it's something I have been involved in researching about, and this is one of my study. So Barara University is, I will just talk about that. That's the main structure of our university. Is in the southwest of Uganda. I think it's a second base in. I don't think it is a second base in Uganda, following Makerere University. So, yeah. So on the right, you can see a group of say people and children, but this really reflects the childhood environment that is favorable for any child to grow. It has to be supportive. It's supposed to be, you see what's going on the right. The mother is playing with the baby. That's what childhood should be. But this is not our case in Africa, because we have many, determinants of this this favorable environment. The optimum environment required for any child to grow is made by the people around them and also by the environment. And that brings in context climate change. So this lady in green, you can all imagine what she was telling that child. We don't know what, but it wasn't something good, right? Yeah, so if a child is exposed to this every day, the stress response system is a physiological response system in the body. So it kicks in, we'll have the hormones going up, and this goes up to prepare the subject, whether an adult or a child, to fight or to flight. So if a child is exposed to this every single day, as they go home, they find mother and the father fighting, as you see on the right side in the background. Maybe the child was playing with their toys, they're having a nice time, and then all of a sudden in the background, the mother and the father start what? Start fighting. So that's household dysfunctions. Contributes to what? To childhood trauma. And you know what happens after? Child goes to school and squats in a corner, as you can see, thinking a lot of things going on at home. Maybe at school they can't make friends because what they are used to at home is not that friendly. So they grew up in that environment. They can't make friends, they can't relate well, and this results into significant mental health impacts. And there's a primary study that was done in the US, the Kaiser CDC group. This study explored the impacts of adverse childhood experiences on mental health, on non-communicable and communicable diseases, on behaviors, on life potential, and the results were striking. One of the findings, apart from what is reflected here, one of the findings showed that children who were exposed to more than 4 adversities had 20 years reduction in their life expectancy. So for example, if in Uganda, for example, I think the life expectancy is about 65 years. So the ones who are exposed more than 4 are likely to barely make 50 or even less. So that's how bad this is. So as we can see, it increases risk for diabetes, obesity, leave alone mental health, but other impacts on non-communicable diseases, COPD, stroke, broken bones, many non-communicable diseases. Now, mental health is at the core of all this. Depression, suicidal ideation, PTSD. I'm glad Professor presented about PTSD. And this could be resulting from many physiological mechanisms going on in the body. Life potential, for example, academic achievements. So we may think that SEEs, actually I think so, that adverse childhood experiences contribute to all risk, all diseases we know worldwide. They contribute to HIV, because the risk behaviors that may result into acquiring HIV may result into what? Exposure to adverse child trauma, child abuse and child sexual abuse. So children have to be protected from the point go, when they are still young, up to when they start realizing life. And what worries me is that more than a child may be exposed to more than one adversity at the same time. So as you can see here, this child is experiencing verbal aggression, or this is emotional violence. Maybe she had just slapped the child, that's physical violence. If it's the same child that lives in the same household, they're experiencing domestic violence at the same time. So you see, as the number of SEEs increase from 0, 1, 2, so as they increase, the risk for negative health outcomes increases. So that's why the other study found that 20 years old reduction in life expectancy. So we conducted a study among university students, considering this as our conceptual framework they proposed in our study. So we thought that exposure to adverse childhood experiences may directly result into academic issues with academic performance and also mental health symptoms. But also mental health symptoms and academic performance are related, because if someone is depressed, they are less likely to perform well in class, and the other way around. So in our methodology, we conducted a cross-sectional study among university students. Of course, we obtained ethical approval. We used the Adverse Childhood Experience International Questionnaire that was standardized by WHO to collect data about 13 SEEs. So it collects data about 13 SEEs. We are going to look at that in a moment. We also assess for outcomes using the PH29, which is Patient Health Questionnaire 9, to assess for depression and suicidal ideation. Family environment, factors regarding the family environment were controlled for in our regression analysis. And our analysis was conducted using STATA version 17 and ANOVA and t-test. These are statistical tests that we use to assess the rigor of our results. So these are the results. As you can see, the lower bar is physical abuse. All children were exposed to physical abuse, all of them. And then the second is community violence, the second bar. So that's about 80%. So as you can see, emotional neglect followed, household dysfunction followed. So these were the 13 ACEs, or adverse childhood experiences, that were reported among university students. Remember, university students are like, they have made it in life, they have surpassed all through all these young, these stages, and they are somewhere, but they're reporting this because it's common in our setting. So physical abuse is number one. But as I explained previously, I said that they are exposed actually to more than one trauma. So you see, most of them reported at least 4, no, at least 5. You see, so from 5 as you go up to 13. So so if you look at 6, those are 13% reported 6 adverse childhood experiences, and as you go up, 2 reported 13 ACEs. So you can imagine such a child who was exposed to all adverse childhood experiences.
So, Doctor, 10 minutes is up, so if you can please.
Oh, okay, sorry. So let me be quick. So this is regression analysis, and we found that academic performance was assessed using self-report. But you see, as the ACEs increased, academic performance dropped down. And for depression and suicide ideation, as the ACEs increased, the number increased, the worse the symptoms, the severity of the symptoms. So physical trauma, physical abuse was the commonest ACEs, as we saw. And you can see the intergenerational transfer of abuse. Yes, and also this doesn't only occur at home. You see, even at school, there is violence. You saw the punishments have been domesticated, and they are not controlled, and our children are exposed to child abuse. So there are many other confounders that would have confounded the findings of academic performance. Could be relationship, dysfunctions, financial issues that would also contribute to childhood trauma. So ACEs are preventable, and they're preventable through today. Yesterday I learned about the protective childhood experiences. So maybe you can adopt that, or you can, explore that and integrate it in our interventions. And I'm glad to share that this study has been published early this year in BMC Psychology. Thank you.
Thank you very much, Dr. Muwanguzi. Questions for Dr. Muwanguzi? There's the mic there. That's
Thank you for the wonderful presentation. I have a question with regards to the number of the results in terms of the people who had experienced physical abuse. I don't know, like in your context, how you explained physical abuse, because I think from the African context, the people who grew up several years back, you realize like spanking was just a way of telling you be in the right path. However, the intention was not to cause bodily harm or injury. So I'm curious to know, based on the 100% saying they had experienced physical violence, was that like control for people who are just maybe thought by the fact that they were beaten a few slaps without being hurt, it was still physical injury? Thank you.
Thank you so much for that question. So the Adverse Childhood Experience International Questionnaire adjusted for that. So the question is not were you spanked when you were a child. So it adds the details of being harmed, how you're experiencing that every day, experiencing it. So there are 2 questions that assess for physical violence, but the questions themselves, maybe you may need to look at it, the questions, they control for that. Yeah, so not all people who were punished were actually physically abused. Yeah.
Okay, thank you very much. I really appreciate your presentation and congratulations. Congratulations on your publication, Doc. So the next person to come up is Mr. Oluyinka Oyeniji, which is he's currently finishing his PhD in the UK, but he's from Nigeria, and he's not a psychiatrist, he's not a psychologist, but apparently he's a lawyer by profession. Is that correct? Yeah. So we are really excited, looking forward to your presentation.
It's the first time I'm going to get people laugh at me that I'm a lawyer. I mean, my parents can't be happy at all.
we are very joyous.
Yeah, but it's the second time I'm going to get the reaction. I find myself in the midst of people doing brain research and, oh well, maybe this is bi-directional or multi-directional, okay? Multidisciplinarity, if you like. All right, before I start, I'm going to run through my presentation, but I think it's fitting to say some appreciation. So first of all, thank you, AGMHI. I've not been to Nigeria since last year because I can't afford the ticket, and that's my home country, whereas in the last 4 years, I must have been home thrice a year. But I'm here in Africa, and I thank you for this investment. I'm grateful. Also, I'd like to thank a beautiful lady who's sitting there almost across me, Olivia Mashabane. She's got a huge impact on my research, and you'll find out why. All right, so my background, you already know. I didn't think I would be presenting. This is the first time I'm presenting this complete work, and she's here. It's amazing. I didn't know it would be like this. I hope she approves of it. So, yeah, my background. I practiced law for about 14 years in Nigeria as of 2017, and I got tired. I mean, it was the same thing again and again. I took to Twitter, and people started talking about ethics of AI, Luciano Floridi and co. And then they were talking about ethics of AI. But anytime I tweeted, they won't respond, they won't retweet. And I asked them, I called them out. I said, why would you be talking ethics without lawyers? And still they didn't answer me. They kept talking the philosophy of it. So I got angry and went back to school and studied science technology policy. And then 2 days before the GDPR was promulgated, I presented at Arizona State University on governance of emerging technologies. And using my legal background, I told them there was a possibility of governing emerging technologies globally. Nobody asked me any questions, so I thought I was doing the right thing. So I went back to University of Sussex in United Kingdom, studied science technology policy, and right after that, accidentally, the only fully funded PhD I could get was in ethics of neuroscience, so here am I. That's why I'm here. All right, so I decided to do literature review of ethics of neuroscience. I've talked about my background, and it's all there. It's situated in EU Human Brain Project, now eBrains, and then of course I'm a student of the Montfort University in Leicester, United Kingdom. So regarding professional memberships, I engage with Society of Neuroscientists of Africa, SONA, INS, Institute of Neuroethics Society. I hope I got that right, Olivia, don't kill me. And then of course, so I'm a member of Nigerian Bar Association, and then I've registered to become a member of AGMHI going forward. So yeah, that's my research. So neuroscience and neuroethics in Africa, what you hear all the time is there's nothing being done on neuroethics in Africa. So again, I got angry, and I decided that couldn't be correct, that we are not doing neuroethics in Africa. So I chose a different approach. But Olivia, God bless you, your 2021 paper on promoting diversity in neuroethics, I came across it when I was lost in my research. My supervisor couldn't help me. I couldn't help myself. But I found that paper fresh from the press, and it talked about the H3 Africa initiative. And then I started to look at, I found NeuroGap, Professor Lukoye. I found Professor Anje's paper. And then you'll see that they helped me to start to shape what neuroethics should be in Africa, or what it is that we have not recognized. All right, so there are developments in Africa. We now have a brain bank in Nigeria, which is part of the H3 Africa initiative. So there are quite a number of collaborations going on. My literature review methods, I decided I wasn't going to do semantic or systematic if you like, because people will say you're counting. So I decided to do scoping literature review. I was asking what would be ethical issues associated with neuroscience or brain research in Africa, and I put those strings into PubMed, got about 140-something hits. I reduced them. Inclusion criteria for me was English language, and if they were Africa-based research. So at the end of the day, I ended up with 70 papers, and then I applied something called snowballing method using Dr. Olivia's paper. I looked at the references she made to H3 Africa, and then I found the remaining papers. Ended up with 316 publications that I just finished reviewing, and I analyzed with NVivo. So what are my findings? I found out that there are quite a number of professional associations in Africa engaged in neuroscience or brain research, HGMI now added to that. I found also countries that are conducting neuroscience research in Africa. I expanded the sources of neuroethics discourse. And then, of course, I also was able to adapt them to the neuroethics questions that I will show shortly. And then I was able to establish what ethical issues emanate from neuroscience research in Africa. And then I'll talk briefly about nomenclature. All right, so these are my findings from Africa, Nigeria and South Africa, a close race there. And then, of course, there are other countries. There are major projects, including PRIME. So up there, you see region. Those are regional projects, and I believe NeuroGap may be there because I didn't situate it in any one country. I put those as regional research. So that's it. Quite a number of countries in Africa doing neuroscience or brain research. So never again will we say we don't do neuroscience in Africa. I also considered what brain diseases were prevalent that were being studied, and stroke was significant, stroke right there, and then a couple of other behavioral disorders and all of that. I also established, this is where you may find your paper or some profound papers there. Olivia's paper is there right there. She made copious reference to ethical issues of neuroscience. Professor Anje, your paper is somewhere there. When I saw your name, Uforiata 2018, your 2018 paper, I coded it and coded and coded. I spent time coding that paper. So these are, I didn't know I was going to be presenting to you or sitting beside you. So yeah, I think God is just leading me and I'm following. So those are publications that talk about neuroethics. What are the ethical issues I've established? These are not everything, but consent is profound, stigmatization, integrity of data. And then I found, especially retrospective research, over 200 publications. So people using patients' data, patients they are diagnosed or treated, and decided to use their data for publications later. Foreign methods and adaptation, your weighing scales, your standards, if they are not validated or adapted to local context, then you may question the integrity of your scientific findings. Data ownership, sharing, and transfer, we remember Henrietta Lacks. That still happens when we have collaborative research, but we can't determine who owns the data, or we are not making recourse back to the person. Drugs administration and impact, I found research that there were medications applied, and then there were also side effects of it. Some of it were addressed. And then access to treatment and care. So for your controls and for those who required attention even while doing your research, do we plan to send them in for treatment? Neuroethics questions for neuroscientists was generated in 2017. International brain initiatives comprising of over 112 neuroscientists all over the world drafted these questions for neuroscientists or those conducting brain research to guide the research that they are doing. So what I did, because somebody asked me a question and I thought it was profound, he said, how did I identify what was ethical? So I then adapted what I had read from this to the ethical issues that I established. So that's part of my publication. And then the next thing I want to also write on, hopefully I get to be able to do that before the end of the year, is to ask the question of how informed research participants are actually in neuroscience research in Africa. With just everybody, for those who write it, informed consent obtained. But if you are looking at issues such as language, do they understand the language? Number two, we've talked about influence power play here. We've talked about, I thought about funding, okay, incentives, what incentives do we give? So I have about 14 issues. In fact, there are people who conduct if you like, anatomical neuroscience, which is they use dead bodies to conduct research. Who gives consent in those circumstances? Morbidity and a lot of that. So informed consent, there are those who use broad consent, there are those who use tiered consent and all of that. There are those who even use utility. So that should be the next paper to discuss how informed indigenous people, Africans are when conducting brain research. So my own reflections, and this is just me, I've asked the question today. Thank you to those who have allowed me to interview them. I also hope to send out a survey. Do we need neuroethics in Africa? Is it paramount when we are looking at healthcare, access to healthcare and all of that? What are our own perspectives, okay? And then, of course, our publications need to be out there because I discovered that there's a certain association, PANS, who have been publishing since 2002 or 2004, and they have 2 volumes a year. Some people never heard of them. I went through, they gave me at least 200 relevant publications to use to discuss neuroethics. So we need to publish, and it must be feasible or visible out there. All right, and then, of course, my references. So next phase of my research, as I said, is I would like to consider how research participants perceive ethical issues in Africa and how they are addressed. I have drafted a survey for you to kindly help me fill. If you can leave that on the screen for a while, please. I will appreciate for you to complete that survey so that we won't keep saying we don't discuss neuroethics in Africa. Thank you, everyone.
Thank you very much, Oluyinka. This is fantastic, and thank you for keeping to the time. If you can leave that last slide up, please, and we have a few minutes for questions or comments.
I pray for you not to ask questions.
But can she comment? Do you want to comment, Oluyinka? Oh, yeah. Professor Atwoli?
Thank you. I mean, thank you very much for examining this not very easy subject to examine, and for the plan you have to develop that field of work. I think going forward, the thing that will make us stop laughing when you're introduced is that you should be introduced as a neuroethicist rather than a lawyer.
Yes, sir. Please
Thank
take
you.
note.
And a doctor with a PhD.
Amen.
Yeah? Hallelujah. All right. Well done. Thank you so much. Thank you very much, Mr. Linka. All right. So the final emerging early career researcher is Darrick Scott. Dr. Scott, if you can come up, please. Dr. Scott is a psychologist. I think he said he is currently working in Chicago, and we are looking forward to your presentation. Yeah, it's up on the board already. Thank you so much.
Thank you. Let me see if I can work this. Okay. Cool. All right. Good afternoon, everybody. Yeah, I want to thank the AGMHI conference organizers and judges. Thank you for the welcome. I've never been called so far so quickly. It was a long flight, and it feels like I was just celebrating the defense of my dissertation, and my co-presenter, Kalo Sokoto, was like, brother, I need you for a co-presentation. And she wasn't able to come. And I'm like, Kalo, I just wanna celebrate. Let me just relax. But she's like, no, bring your dissertation, let's do this. So here I am. I also want to just remind folks, Kalo wanted to be here. She couldn't be here, but she made a video. Thank you. She made a video recording, and her email is in the booklet, so feel free to just say hi, or if you have any questions. I want to ask for folks to make room for, we were co-presenting both of our dissertations, so if you can make room for both of our studies and, and me sort of talking about the overlap, that would be great. I won't be able to speak to, I guess, many questions about her study, but maybe I'll try. I'm sure she'll answer your emails, but I'll be able to speak to questions about my study for sure and just talk about the overlap within our studies. So the title of the presentation is Decolonizing Psychology Through Centering Black Mental Health, Racism's Health Outcomes and Anti-Racist Resistance. So just briefly about myself, I'm a postdoctoral fellow at the Cook County Health
juvenile temporary detention center. So I work with youth in lockup, doing counseling and treatment in cells with children. So it means a lot to be on the continent and to be here. I started that position in the beginning of October, so it's sort of fresh in a way. And it means a lot to to be on the continent and think about the experience of detention and trauma. My most important role is being an uncle. One of my most important, I guess the most important thing about me, or my favorite thing about me, is being a Pan-Africanist. And by nature, I'm an art enthusiast, nature enthusiast. I'm a Chicago native. In terms of positionality, briefly, there's no conflicts of interest, and I realized that the tools used to do this dissertation and a lot of this information comes from the U.S., the West. So Kalo and I wanted to center a more decolonial lens. We're thinking about speaking to our brothers and sisters on the continent and speaking on behalf of Africans in the diaspora. So in terms of the background for our presentation, we wanted to talk about social determinants of Black mental health. Our dissertation sort of overlap in thinking about racism and the impact on the mental health of Africans in the diaspora. So we know this conference centers on racism as an environmental stressor, and obviously it impacts our ecosystem, right? But it also impacts our social environment and our ability to advocate for ourselves and for our environment. So it's essential that we talk about racism, and I appreciate this conference for giving us a chance to really sit with the concept of the environment and what it means to our health and well-being. So I'll discuss racism and the impact on health. I'm sort of centering on depression, Kalo is centering on anxiety. And then we'll sort of close with thinking about resistance against racism, which is a key sort of component of my dissertation. And then we'll talk about what this means for us as professionals, folks in the community in the US, what it means for South Africa, and what it means for the continent broadly. So my dissertation is centered on the construct of historical racial trauma, described by Dr. Braveheart as the collective psychological, emotional, and cognitive distress produced by an intergenerational impact through the repeated experience of oppression. So this is more of instead of a singular event of intergenerational sort of trauma or intergenerational experience, this is the accumulation of emotional and psychological oppressing and distressing events. So if you think about this within the African American context, we can think of, building on Jim Crow, building on the Reconstructive period, building on mass incarceration, the crack epidemic, so many different cultural experiences that have accumulated over time and created this ongoing trauma for generations. So folks in my generation, for example, are carrying the trauma of Michael Brown, the trauma of George Floyd, but also carrying the traumas of our parents from the civil rights era and the periods before then. So Dr. Braveheart centered most of her research on the indigenous population in the U.S., otherwise might be referred to as Native Americans, and highlighted themes of trauma testimony, trauma response features, and transcending the trauma. A lot of this is sort of grief-based, sort of focus on recovering from trauma. Very little research has been done with historical racial trauma for African Americans. So I wanted to center that, and the previous research did talk about stigma, cultural mistrust, and the impact of a lack of African American mental health providers. So in my efforts to expand the understanding of historical racial trauma as it relates to the African diasporas, particularly African Americans, I wanted to look at the relation between historical racial trauma and depression, seeing if this relation was mediated by internalized racism, which we know is sort of like having the oppressor's understanding of the self, or having a lens of self-hatred, and then seeing if that relation was moderated by both self-compassion and resistance against racism. Self-compassion being an experience of self-kindness or understanding of common humanity, and resistance against racism being taking a stance of empowerment towards experiences and encounters with racial oppression. So it should be noted that the alpha score for self-compassion was significantly low, so it was dropped from the study, but I did keep resistance against racism as a moderator. So this is a moderated mediation model, and I conducted the analysis using a process macro, so you can note that as well. I recruited folks who were 18 and above. I conducted a quantitative study, so all of my measures were put on Qualtrics online. And I was primarily looking at folks, African Americans, who identified as descendants of U.S. enslaved Africans. I recruited in various settings that were common to African Americans, community gatherings, social media, emails, and various networks, and my sample size turned out to be 100, the average age being 34 for my sample. Just quickly, these are the measures that I used. Just briefly highlighting the impact of historical racial trauma, which was one item. To what extent has historical racial trauma impacted your life? This is a 5-point Likert scale. And additionally, I measured depression, resistance against racism, internalized racism. Yeah, those are my measures. So in terms of my results, internalized racism was positively associated with depression, so we can kind of understand how the self-hatred was associated with some of the main tenets of depression, being sadness, hopelessness, anger. Another sort of finding was historical racial trauma being significantly predicting internalized racism and resistance against racism. So we can think of this as folks who are identifying with the sort of the ongoing trauma, also experiencing or being likely to experience self-hatred rather. And then we can also think of the other part of this finding as folks identifying with or being folks who are likely to acknowledge sort of their experience with ongoing racism as being more likely to engage in resistance against racism. Looking at the third finding here, resistance against racism significantly moderated the relation between the impact of historical racial trauma and internalized racism. It also moderated the relation between the impact of historical racial trauma and symptoms of depression. So when resistance was high, this was more commonly sort of presenting a stronger relationship between historical racial trauma and internalized racism, and also creating or being more likely to predict a stronger relationship between the impact of historical racial trauma and symptoms of depression. And then lastly, with internalized racism, this was a partially mediated relation. Internalized racism did mediate the relation between historical racial trauma and depression, and it was found to be an actual moderated mediation effect. So mediation had a stronger impact for folks who were more likely to engage in resistance against racism. So ultimately, this brings up the importance of thinking about the experience of resistance against racism. Given that there's this connection with internalized racism or self-hatred, there's this identity component that should be noted and should be observed for folks who are consistently engaging in activism. And I think that, we just need to be thoughtful about, how folks are engaging in activism, thinking about the best ways to take care of oneself after an experience of racism, or kind of taking a stance of empowerment against racism, thinking about the proper strategies that are going to facilitate wellness in the long term for those who are engaging in activism. And we also should think about the experience of anti-Blackness, particularly for those who are engaging in activism. I think we kind of see them as heroes and just being like, oh, they can handle it and they got it. But these are the folks who are sort of encountering these negative, really nasty views of Blackness and being African. And it's not just people who are in organizations, right? A lot of us are having like negative racial encounters on a daily basis. So this is, we are the folks who need to be thoughtful about how we engage with negative images and negative narratives about people of African descent. And then lastly, thinking about family treatment interventions, I think it's essential to think about how the collective sort of supports movements of activism and stances against anti-Blackness, because it can often be sort of an isolating experience when we take a stance against racism. I'm seeing that we're close to time.
There's still a video to play, right?
Yeah.
So can you please move?
Yeah, we're right here to the video. Yeah, sorry about that. How can it be played? Is it?
Sawubona My name is Kalo Sokoto, and I am a Kenyan doctoral psychology resident at Boston Medical Center here in the US. It is a great honor to participate in the African Diaspora Global Mental Health Conference, together with my colleague, Dr. Scott. I also regret that I could not join you in person. I will go ahead and briefly discuss my dissertation, which I successfully defended and published in the last 2 years, where I looked at racism in dental settings and its implication on dental anxiety and dental care utilization among Black identifying women in Appalachia, USA. So today, 1 in 5 adults in America have experienced discrimination while receiving healthcare. Even though racism is the most reported type of discrimination in healthcare settings, little is known about its impact on dental outcomes. There was no prior study that looked at experiences of racism in dental settings before I did my dissertation. As such, I thought to look at how racism looks like in dental care settings and its impact on dental anxiety and dental visits. I hypothesized that there would be an association between racism in dental settings and the frequency of dental visits, mediated by dental anxiety. Everyday racism was defined as the chronic race-based unfair interactions embedded within institutions. And through the Center for Oral Health Research in Appalachia, which is the organization I was affiliated with, 268 Black identifying women residing in West Virginia and Pittsburgh, which is in Pennsylvania, participated in our study by completing the Everyday Racism Scale, the Dental Fear Survey, and the Dental Visit Question. Examples of items that were asked in the Everyday Racism Scale were, have you felt like a dental provider was not listening to what you were saying because of your race? And have you felt like a dental provider was afraid of you because of your race? What I found was that more than a third of the women had experienced racism in dental settings. Most women felt like they were not listened to, they received poorer services than other people, and that they were treated with less respect than other people. And all of these, they explained, was because of their race. We also found a significant relationship between racism in dental settings and dental anxiety. And dental anxiety was found to be a significant predictor of dental visits. Finally, racism in dental settings, together with dental anxiety, predicted dental visits. These findings suggest 3 things. 1, Black people simply want to be treated like human beings, including by their dentists. That is, with respect, quality services, and to be heard. Second, the psychological impact of racism in dental settings is a likely barrier to dental visits. And finally, clinically assessing and addressing past experiences with racism in dental settings may reduce dental anxiety and in turn increase dental visits among Black women. So even though this study was conducted in the US and in specifically Appalachia, these results support previous literature on racism in healthcare and its impact on mental health and health behaviors among Black identifying people. And so this is a global experience. Thank you for your attention, and I welcome questions and comments through email, which Dr. Scott will be is able to provide. And I look forward to seeing you next year in person.
Yeah. Is that right? Thank you. Sorry, we really run out of time, so if you can just last comment. Yeah.
Yeah. So just as a last comment, sorry, trying to go next. So obviously the overlap with our studies is just sort of thinking about the dental environment and the sort of the impact of racism. We want to just highlight I guess in closing, just the strength-based interventions, really thinking about finding, when we're working with patients and folks who are sort of dealing with some of these negative experiences, helping them to find strength, helping them to be empowered to establish accountability, empowering our peers to be thoughtful about treating people of African descent like humans, treating them with care, and being sure to document and take seriously the mentions and the descriptions of racism and oppression. Thank you.
Thank you very much. Thanks. There is, I was going to ask just for one burning last question. There's a question at the back. Sure, thank you.
Thank you so much, Dr. Scott, Darrick. Very interesting piece of work, very empowering and impactful. But it would be interesting to know if there has been any studies and if you've done any comparison on discrimination overall, whether it's race or it's gender or it's sexuality or tribe, and how that translates to impact of that as a stressor for mental health issues. It'll be very interesting to quantify. Thanks.
I really appreciate that question, and we'll be happy to follow up with you. I'll be brief and just share that I didn't do any comparisons just at this point, but I do think that's sort of the next step of this study. I did collect data for a number of black ethnic groups within the U.S., but just my analysis was done on African Americans. So I think that I am able to kind of do some inter-ethnic sort of comparisons with the Caribbean, with the continent, et cetera. And then there's just a lot of narratives and I think prior research on the impact or sort of the how gender and race sort of intersects in the U.S. and in the diaspora, with there being a lot of sort of sexual discrimination for Black women. And some other things for Black men that the literature still needs to sort of go deeper in, but there's a lot, I think, to dig deeper in terms of the intersectionality between tribes, between ethnic groups, and between genders. So thank you for noting that, and I'll be sure to think about that in the next step of the study.
All right, so thank you so much. Thank you very much, Dr. Scott. Thank you. Can I ask Michelle to come up, please? Dave to come up. I think I just wanted to say that these emerging researchers, most of them were funded through a travel grant that we received from the National Research Foundation of South Africa. So we just wanted to say we are grateful to that, and